And I see you also recording.
Yeah, I thought that's a question for Gerard maybe, because normally we record our webinars to be able to have people who could not attend now to see it later. It will be included in a restricted environment. I think we will not publish it on YouTube. Is that okay for you?
Yeah, it's fine for me. Yeah, no problem.
Okay, wonderful.
And I understood from you, Diederik, that Coral could not join us?
No,
she did not contact me. Okay.
No, I was a bit surprised by the fact that she only contacted me. I thought, well, it's more logic to contact you even, and then with me in CC. But anyhow, that's how it is.
Yeah. And no news from Dina?
No.
Okay. So I suggest we wait for 2 or 3 more minutes and then we start. Ah, there's someone else coming in. Someone is waiting. I think Diederik, can you let him in, or is he? No,
should go automatically.
Oh,
it's not like Zoom where you have to accept.
No, that's true. Yeah. Okay. So who is the 6th person in the webinar? Can you please show yourself?
No, he's not yet connected, I think. So.
Okay.
Virle is joining us.
Okay.
There is somebody else. Hi, Virle. I think you are connected.
Yes, Diederik. Hi, everyone.
Hi.
I'm having troubles with, but I'm here.
Great.
Very good. Very welcome. I give us 1 more minute and then I think we should start.
Yeah, you're right.
And Nele. Hello. Hi, Nele. Do you hear us? You don't hear us? No. Okay. I think we should start. Very welcome to this second webinar organized by the European Forum for Primary Care and then especially the Working Group on Prison Health. This is our second webinar We had a first one earlier this year, and the second one is actually a follow-up of the first one. My name is Anke van Dam. I am chair of the working group on prison health, and I'm also a member of the advisory board for the European Forum for Primary Care. The first webinar we organized this year in January was actually presenting some systems of healthcare in prisons in 2 parts of the world. There was an example of how care is organized in prisons in the UK and specifically in Wales. And we also had an example from Kyrgyzstan. And we noticed, of course, quite some differences in how our care is organized. We took these examples in a position paper that we are going to develop. And that position paper is actually looking in, what kind of role primary care should play, can play, must play in the healthcare in prisons. And we are preparing a position paper to do recommendations to get primary care also more involved. And then also looking at the role of our forum in this respect. We felt that we needed actually more information and more exchange, actually a better opportunity for exchange of experiences with more people. We also thought that the best person who could give insight in how healthcare is organized in prisons is someone who experienced this by him or herself. And that is why we invited Gerard Smits, to tell us his story and his experience in a Dutch prison. So what we are going to do during this webinar is actually hear the story of Gerard, and then Peter Groenewegen, who is the author and the developer of the position paper. He will present the outline of the position paper and present some themes and topics where we very much like to have your input in. We are with actually quite a small audience, so I suggest that we do a very quick introduction round of people. So also to know for Gerard who is at this webinar. So Diederik, maybe you can start.
Yes. So I'm the coordinator of the European Forum for Primary Care, Diederik Arendonk, already for 15 years trying to connect people around different themes, always related to primary care and the interprofessional approach to primary care, and how can you organize primary care and in the best way. And I think that's also related to this working group and this position paper to be developed. So I'm happy to host you in this webinar.
Yeah.
Maybe Virle?
Hello, everyone. Can you hear me?
Yeah.
Yeah.
Okay, so hello, good afternoon. My name is Virle Vinke. I got involved in working on prison health actually when I was a researcher at the University of Ghent. I was involved in 2 research projects on prison healthcare at the time. At this moment, I'm no longer working in Ghent University, but I work in an organization, an umbrella organization of community health centers in Belgium, in Flanders. But I'm still working with the federal government of our country on thinking about prison healthcare in Belgium. So still interested.
Thank you. Sukma, can you present yourself?
Yeah, thank you. Hi, everyone. Thank you for this opportunity for me. I'm actually a family doctor from Indonesia, Jakarta. I'm as a member of a group, a working group in this country to develop our first family doctor education in Indonesia, because we don't have the family doctor yet. So we now develop, and I want to know more what the actually our goal is to strengthen the primary care. So in this webinar, I want to know more what is the role of the family doctor or primary care for the prison, in the prison. Yeah. Thank you, Anke, for the opportunity.
Well, thank you for joining us.
Yeah.
And I hope we can help you with this webinar.
Yeah, thank you.
And Nele, could you introduce yourself and your interest into prison health?
Yes. Hi, good afternoon. Nice to meet you, everyone. So as you know, my name is Nele and I'm a speech therapist. But I also do an extra master in management and in healthcare at the University of Brussels. And the last year I did my internship regarding the reorganization of specialized medical healthcare inside prison, and we did a pilot project in the medical center in Bruges to see if there is still a future for specialist medical services inside the prisons. So it's kind of it's kind of interesting just to know how you think about it, and I'm looking forward for your presentation.
Thank you so much. You're very welcome. Nasser?
Yes, my name is Nasser, and I work for the Ministry of Health of Oman. I did my master in quality management, Birmingham, UK, and my PhD has from the Netherlands, also in quality management. Right now, I work in primary care, Ministry of Health of Oman, and I thought this is an excellent opportunity to learn about primary care in the prisons.
Okay, thank you so much for joining. Very welcome. Peter?
Nasser joined us already in 2010, I believe, in Pisa. So welcome back,
Okay.
Nasser.
Okay,
Yes.
very good.
Thank you, Derek. Thank you.
Yeah, a good old friend. Peter?
Yeah, my name is Peter Groenewegen. I'm a researcher at NIVEL, the Netherlands Institute for Primary Healthcare. I've been working in research for the whole of my career. I'm a sociologist by training. My interest in prison health is on the one hand that I think it's really a socially very important area for policy and research because of the changes in the prison population and the lack of good policies with regard to prison health. And on the other hand, I've also been doing some research based on large existing databases together with my colleague Anja Dirkswager, who couldn't be here. She's working at the National Institute for Criminology, and her specialty is research in prison health. But she had to accompany her father for his second COVID vaccination. So that's a very happy day for her, and of course for her father. And I've been working within the European Forum of Primary Care from the early start. So I was one of the founding members of the European Forum and still involved from the side.
Thank you so much, Peter. And I'm very sorry that my phone rang. So I have to be on charge because of the COVID vaccinations. So that is my other job. Gerard, we move on to you. Please tell your story. Give us some insight. How does it work with when you want to have care from a doctor?
Okay, good morning, everybody, or good afternoon, I should say. Yeah, my name is Gerard Smits, and I've had a lot of experience with healthcare in prisons in Holland. And in 2003, I think it was, I was sentenced to 6 years in prison for smuggling cigarettes. That was the only crime I ever committed. And it took until 2012 until the execution process of my sentence started. And first they took me to the prison hospital. There's one small prison hospital in Holland where you're supposed to get care. And after 2 months, they sent me home because they couldn't give me the care that I needed. And this repeated itself in, let me think, 2015 and 2016. They tried to put me back in prison again. And then they leave me alone until, what was it, November 2018. And then they put me in a prison in Sittard in the Netherlands. Basically, they just threw me in a cell, and because they wanted to finish my sentence. So this didn't go very well in a medical for medical reasons. But anyway, in September 2019, I fell in my cell because there was like how do you call it? The floor of the cell wasn't even anymore. There was damage that they didn't fix. And I basically slipped and fell in my cell. It was like 11 o'clock in the night, in the evening. And I used the intercom system because I felt something is wrong with my foot. And first they said, oh yeah, we will see to it tomorrow. And then, well, I did have a lot of pain. So eventually somebody showed up at the door, but in prisons in Holland, they are not allowed to open the door in the evening or the night. So they looked through the small hole in the door, and they said, "Oh yeah, we will see to it tomorrow." So I went to bed, and next morning I tried to get an appointment with the doctor of the prison, and they said, "Yeah, you need to fill in a form, and we will see." And then it took like 3-4 days until I was invited to go to the doctor, and he looked at my foot. And under my foot was a real big bump, you know. And he said, "Well, it's just a hematome, you know. It's just blood. There's nothing wrong, you know. Just wait it out, and it will go away by itself." But it felt really bad, and I kept going to the doctor in the months after that. And he all the time he said, "There's nothing wrong. Don't worry. It's all okay." And then it was like October. Then they sent me for an echo to the hospital, and in the hospital they said, "Yeah, there's something wrong. You need to go and see the surgeon for that, because we cannot determine what it is. So let the surgeon look." Then it took like a lot of time, like 4 weeks, until I finally got an appointment with the surgeon. Something went wrong. They later admitted that. Something went wrong with planning the trip to the hospital for that. And then the surgeon said, "Well, this is not good, this foot. We need to make a CT scan." And she wanted to have that done within 2 weeks. And again, the prison failed to organize it, so it took like 5 weeks until I finally got the CT scan. And then it was like on the 21st of December, the day before Christmas, I finally came to a orthopedic surgeon who said, "The whole inside of your foot is completely messed up. All the bones are broken and displaced, and this is an extremely serious situation." And she basically put me in a plaster all the way up to my knee, and that was it. And then they put me back into a prison cell without wheelchair, without care, without nothing. And then they realized later, after like 10 days, that I couldn't stay in the cell with this because I was not allowed to walk, you know. So how can you function in a prison when you are not allowed to walk? So then they sent me back to the prison hospital. That was like January 2020, the 3rd of January. And there they said they again couldn't give me the care. And they released me on the 10th of February last year. And I had 3 operations since then on my foot. It is a so-called Chopard fracture. And basically for the rest of my life, I am handicapped because of this. And the discussion is now, because I had like 3 operations, it's still not good. So they are thinking either to do another operation or to take my foot off and part of my leg. because of the care I didn't get, basically. And I have a lot of cases now against the prison and also against the doctor who basically just didn't care much, you know. But the big problem in the prison in Holland is that there's only medical assistance from 8:30 in the morning until 4:30 in the afternoon. So if something happens to you in the night or in the weekend, there's nobody there in the whole prison that has any medical experience. So basically, the prison wardens, they have to determine if you are in need of medical help, you know. So they say, okay, maybe we should call an ambulance, maybe we should call a doctor from outside. Sometimes that can wait 3 hours until he's there. And this is the reason why sometimes people die in prisons in Holland because of heart attacks and things like that, because there's not one person that has any medical experience. And if you look at the European prison rules, they are very clear with this. They say there must be at least a nurse or somebody with some basic medical knowledge should be available at all times. But this in a well-developed country in Holland, this is not the case. And basically, I'm one of the victims of that. And for the rest of my life, if I can ever walk, it will be not for a long time or short distances and stuff like that. So I'm not really pleased with this situation. But this is typical, and I saw many of these cases, and where people can become very sick without care. And yeah, this is basically what happened to me. And now I'm home, and they still want to execute my sentence, and they don't realize the fact that I am basically handicapped because of what they did to me, because this is how I see it, and this is also a reality. And they start to lose some cases now against my lawyers, who are basically also trying everything to get justice for what happened to me. And yeah, it is hard to live with that, and this is how it goes in Holland, you know. So yeah. That is my story, basically, in short. I can make it very long, but this is basically the short version of what happened. Yeah. And now I'm sitting home. I have this plastic walker on my leg, because I was in hospital from January until March, 47 days, with an infection on the foot again, and now I have to wait and see. And basically, it's just waiting and see if I can ever walk again. But the organization of the care in the prison in Holland is just very bad. If you compare it with other countries, it's really unbelievable.
Let me go back to that, Gerard. But yeah. Thanks so much for sharing your story, and thanks so much also for giving us the short version, because there we had already some calls, and you shared already quite some details with me, and it is, you know, it's really very sad to hear your story, that it started actually with not getting the right care from the start, and then with all the consequences it had up till now, and actually you are based and fixed to your chair, you cannot walk, and you have a foot that is dysfunctional.
Exactly.
Exactly, yeah. So we move to the what is wrong in the Dutch prison healthcare system. We move to that later. Are there any questions to Gerard from the others? Questions for further explanation, or?
Ask me anything.
Peter first.
Yeah, it's a terrible story you're telling, Gerard, and I think this is very important that we have these kind of inputs. I think there are a couple of issues. First of all, and it's more like observations than questions to you, but my observation is that there is apparently not a well-functioning primary care system, at least in this prison, because then there would have been a doctor, also a doctor at night, or at least a nurse who could have a look at your condition. So it's not comparable to primary care outside prison, which is one of the moral issues that we, or ethical issues that we would say you need to have the comparable care in the prison situation and outside. The second thing, which you probably cannot answer, but other people maybe, is whether this is a terrible incident or whether this is structural. If it's a terrible incident, of course it's a big problem, and we should investigate incidents and try to find ways of avoiding them. But if it's structural, there's a much bigger problem which asks for a different approach. So these are my observations on this.
Yeah.
Okay.
Any other, Diederik? Yeah.
Yeah. What is our? I agree with Peter, Gerard. Thank you for sharing this story, which has an impact on your life, and that's probably forgotten by many bureaucrats in the system. That's a bit the feeling you get. Whereas I think care should be provided everywhere, as Peter already stated. What we are actually very interested in, how did it evolve after your the care or the non-care you received in the prison? You were released because of your physical condition, and how was the medical information transferred to the primary care level when you reached your normal home? How was there any transfer of knowledge, of experience, of whatever by the medical profession?
I can be short with that. They basically put me outside of the Scheveningen prison hospital in a wheelchair. They didn't provide any transport, so a friend of mine came to pick me up, and they never bothered to contact my house doctor. They did nothing. Basically, they knew in the hospital where they close to my town, where they found out that I had such a bad fracture. They knew about me, and I basically had to call them myself and said, I'm out, can I come? And then they gave me the care. And then I myself had to ask, after I got out of prison, I had to ask for the medical file. It took like a few weeks, and then they sent it to me. But there was absolutely no transfer of any information or any medical record to outside doctors. They just don't do that.
No, so, yes, I heard that before, indeed, and that is quite common, actually, also with other ex-prisoners. Yeah, that's true. If there are no other questions, I'm also looking at the time, then I suggest that we first look at the presentation of Peter, where he will share with us some points for discussion. And then I think then we also come to the point what to do about the accessibility to healthcare. How can we improve that in the different prison health contexts, and then also related to family doctors and primary care doctors. Peter? We don't hear you, Peter.
Yeah. Yeah. Okay. I prepared a brief presentation. So Diederik, if you move on to the next one, which is the outline of the position paper. The idea is that within the European Forum for Primary Care, we write position papers about important issues in primary care to influence policy and to advocate for strong primary care. In this case, the outline of the position paper is that we have a brief introduction and then describe the problem situation based on what's known from the international literature on health of prisoners, on the organization of care, and on the role of primary care. And we are in the process of doing this literature research, and I've reported about that in the previous webinar. So what I can say is that that there's a lot known about the health of prisoners, which is in general worse than comparable people outside the prison situation. And it is not only simple acute problems, but also complex problems related to the interactions between mental health and physical health, and with multimorbidity. There's not much known about organization of care during the prison situation, but we're still looking for the right literature. And there's especially not much known about the role of primary care. There is some literature on interventions to improve the health of prisoners, but these are single interventions and not integrated care for people with, for instance, chronic conditions and mental health and physical conditions. But that's going to be finished soon. Then in this position paper, there will be a couple of examples of good and bad experiences, as Anke already mentioned at the beginning, and one of them or two of them have been discussed last time, and there will be a couple of examples. But then a position paper also should say something about the point of view, the standpoint, the recommendations of the European Forum. And I've been thinking of a number of issues that we can use for the position of European Forum. And you should know that the European Forum has three pillars. One pillar is the primary care professionals, the people who actually work in primary care. The second pillar is policymakers, both at national level or regional or local level. And the third one is research, research in primary care that provides the evidence on which the professionals work and on which policies can be based. And after this slide with a number of basic points of departure, I will discuss some topics based on each of these perspectives. And so in total, I have 4 of these slides, and each of these slides end with a question for discussion. Now, the first one is about the basic points of departure. First of all, we think that prison healthcare is or should be part of primary care and public health. Basic is also that we think we should involve prisoners or former prisoners and their family or next of kin in developing ideas about the practice of prison health care, about the policies around prison health care, and in research about prison health care. And that's why I'm very glad that Gerard is here now, because it shows you that it is not just words, but we actually are very glad to be able to hear your story. Secondly, this normative principle of equivalence, I already mentioned that. That's a kind of a normative principle that says that care in prison should be of the same quality as care in the community. And apparently in Gerard's case, this was not the situation. There's also the principle of equity, equal care for equal need. And that means that if people have more complex care needs, they should also have more complex care, or care that is matching to their problems. And if you combine the two, it may be necessary to provide more or different kinds of primary care to prisoners or ex-prisoners that take their elevated healthcare needs and complexity of the healthcare needs into account. So it's the equivalence principle is not that they should get the same care, but they should get the care that is tuned to their problems. And finally, the prison situation provides the opportunities to improve the health of prisoners. It should be an opportunity to address poor health, to work on prevention, and to reduce health inequalities. So these are, in my view, the backbone points for a standpoint of the European Forum of Primary Care. And my question is, do you agree with that, or do you have other issues that are basic basic issues that we should take into account in formulating our position. Back to Anke.
Yeah. So who would like to react? So that is the point of equivalence. Sukma, yes, I saw your hand, please.
Yes, I'm very interested in equity. Equity is, I think, equity is the main issue, because some people think that all of people in the prison is a bad people. So why we have to take care of them? We have to punish them, not take care of them. So sometimes they judge like that. So the health facility is not equal inside and outside the prison.
Yeah, I think, yeah, that's a very good point indeed. So equity is actually key to the care that we have to give next to equivalence, by the way. But I think a lot of prisoners and ex-prisoners do face stigma and discrimination.
Yeah.
So non-judgmental care is actually also one of the principles that I think we should include. Nele, did I see your hand as well? Yeah, please.
Yes, so it's I'm Flemish, so and we already in Belgium we already have like the primary care included in prison, also secondary care. But the thing in Belgium, it's more about the quality of the services that they deliver. And one of the problems is the finance structure. So I'm not sure if you, like in the Dutch country, if you would include primary care inside the prison. I don't know if it even fits in the scope of this presentation, but who is going to finance it is for the Department of Justice or it's for the Department of Healthcare. Because we see that the doctors and also specialists are less paid to have a consultation inside prison, and it's influencing the quality of the services.
Yeah.
So I don't know how the finance structure will be in the Netherlands. Is there already the discussion about? Or?
Yeah, there is discussion, and actually it is an ongoing discussion also by WHO. What WHO actually suggests and advise is that you put the prison healthcare under the Ministry of Health and not under the Ministry of Justice. And in the Netherlands, it is the case. The financial structure is located under the Ministry of Justice. So there indeed, so although the Ministry of Justice says, well, there is actually no problem with that, we deliver good care, but we also hear otherwise, and especially the story of Gerard is a good example of that. But that is a discussion that is already going on already for, well, decades, as far as I know, at least the 2 decades that I worked in prison health, and initiated by WHO. But I think it's indeed a good point again to take up for the policymakers.
Yeah, exactly. It comes back at the slide of the policymakers, but Peter will continue on that. Yeah.
Are there any more suggestions or ideas for this? Yes, Veerle, please. Yeah, you of course you can make a contribution.
Thanks. Sorry, I don't seem to find the raise hand option here, so I'll do it like this. Of course, I don't know what will be in the rest of the presentation. A word that popped on for me is the idea of safety. I think safe care entails the aspect also of equitable care. It gives an answer to the point that Nele raised, of a very true point of the lacking of quality of care in prisons, which I think is general. And also for me entails this idea that we're touching upon on the funding of care, because what we see is when GPs are funded by not by the healthcare system, but actually by the I lost the word.
Justice system?
Yeah, justice system. Thank you very much. That the experience that prisoners have is very different towards these people, because they are paid by the same institution that's incarcerating them, and it changes very much the relationship between a patient and a care provider. And for me, this is also really an essential thing, that the care is safe in all these different aspects, neutral, with a good quality and equitable indeed.
Yeah, very good point. And actually, you reiterate what Nele said. Yeah. If there are no other hands, then I also would like to make a suggestion. Is that I think the starting point is also the facility, the prison facility should be in good conditions. So enough ventilation, well, hygienic control, and these kind of things. And there's also, of course, a whole list of already checklists of that. If there are no further input on this slide, and maybe, of course, you can always come back to this point, but I suggest, Peter, then we move on.
Yeah, and you will see that some of the points that were mentioned in the first round of discussion come back in the second, third, and fourth round. First, the perspective of primary care professionals, and I've a number of keywords here that I will very briefly introduce. The first is awareness. Primary care professionals also outside the prison situation should be aware that some part of their patient population consists of former prisoners, whether they know or not, and they should be aware of that, and probably also ask people if that's possible in their doctor-patient relationship about their experiences. The second thing which was already mentioned, is that the need for a respectful and open-minded interaction with no discrimination or stigma, the importance of building trust or rebuilding trust. The third one is related to the personal competencies of people working in prison healthcare teams. They need to have the right education. Of course, that's also part of the policy and organizational part, but it's also an individual responsibility of primary healthcare professionals that they only do work that they are trained for and that they feel competent in. Person-centered care. So it should not be only processing the most efficient way of processing people, processing patients, not only acute care, but also a focus on long-term treatment, on prevention. So the person should be the focus and not making the prison processes smooth. And this probably also is related to this issue of governance of prisons, whether they're governed by the Ministry of Justice or the Ministry of Health. As I said, treatment and prevention are important. Long-term treatment of chronic conditions, prevention focused on lifestyle health promotion should be part of healthcare in prisons, and continuity of care. Prison and the community. The Diederik's question to Gerard relates to that. Is there any continuity in terms of exchange of medical information, for instance? But there's a lot more of that. So these were the key words that well, Diederik, you move to the next one.
Yeah.
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 Of course, it's a bit artificial to do this in these parts, but it makes the discussion probably manageable. So I have these keywords to characterize what we as a European Forum for Primary Care would say are important issues in how primary care professionals should relate to this issue of health of prisoners and former prisoners. And again, back to Anke and open for discussion and additional issues.
Yeah, so the floor is indeed yours, and I think what we definitely see here in this slide of yours, Peter, is that the situation in the prison is an unhealthy situation. I think that should also be clear. So a lot of prisoners face a lot of mental health problems, and to be isolated from your relatives and so on, that also brings in a lot of burden. Please, any ideas and suggestions? What do you think about these bullet points? Should we add a bullet point, or should we? Yeah, Nele. Nele, please. Yeah, go ahead.
I think these keywords perfectly fit in the situation of like a multidisciplinary centered healthcare team inside of prison, where we have like a number of people like social workers, psychologists, nurses, physicians, to provide healthcare, and also to that the healthcare provider, from the first day that the inmates enter the facility, monitor and yeah, just follow the patient from the first day until they actually leave. And this should reduce like the fragmentation and the unnecessary referrals, and it should encourage the continuity of care, I guess. And I think if you have a multidisciplinary team inside the prison, it can also change the culture where those people work in. And if you have a team, it's maybe like stimulating for the environment, and they can motivate each other, and it will also influence the quality of care that they provide. So that's what we're thinking about in Belgium, to expand primary care. But especially within a multidisciplinary team, and we think we will facilitate all those key words that you just described to us.
And what do you mean? What kind of disciplines would you include in that multidisciplinary team? Say it again.
So we see, of course, nurses, general practitioners, but physicians, like the kinesiist, the I don't know the word in
occupational therapist.
Yeah, or physiotherapist. Yeah.
No, occupational therapist.
Yes. Okay. Thanks for the translation. A social worker, and right now we see that it's too fragmented. Even in Belgium, they have one appointment, and then the external psychologist is not coming over, or just once a month, or just in 2 months, because they don't work inside prison. They just come over actually when they want to come, and that's what's a big problem here in Belgium.
Clear. Yeah. Thank you.
Can I just refer to that?
Yes, Gerard, please. Yeah.
Okay. There is a few aspects that a doctor in prison makes his position different from a doctor outside. What you do see is that a lot of prisoners try to benefit from going to the doctor. This can be small things like an extra mattress because they have a back problem. People that want a sick note so they don't have to work, things like that. You know, a lot of prisoners go to the doctor just to find a bonus, you know. So it's not really easy for him to determine who is serious and who is not. That is a big problem. The other issue is that in the prison in Holland, what happens is that there is absolutely nothing provided there in the way of an X-ray or something like this. You need to go to hospital for everything, and in going to the hospital, they have to organize a guarded transport. So they need 2 or 3 guards, a special van, and then to take somebody to prison. So I found out that, like a prison with 400 people, they have so many transports per year. So the doctor is under a bit of pressure from the director of the prison if suddenly the number of hospital transports is higher than normal. So this is also a limit for him, like a limitation where patients should be sent to hospital, but the numbers say, oh, this month you already sent so many, so you know, we will do it next month or something, or next year, whatever, you know. It's just difficult for him to, he's under pressure with that too.
Yeah, no, I think that these are very valid contributions, because that also shows that the atmosphere in prisons, and and it shows sometimes the difficult relationship between the general practitioner, the primary care provider, and the prisoner. Yeah, and I think these are very important points.
Yeah. There's definitely a lot of difference between a GP outside and inside the prison, and he has like he has a double role. One, he's supposed to be your GP, but he's also working for the prison, and this double role is. I spoke with the doctor about this many times. For them, it's difficult because basically they are also under pressure from what the Justice Department expects from them. So most of these doctors have also a normal practice outside with civilian patients. So for them it's difficult to separate the daily life practice outside and inside, because and after 2 years they basically try to adapt to what the Justice Departments expect from them, and that's a big difference.
No, definitely true. Diederik,
yeah, just a small comment on that. I think these are indeed valid points, and it also all relates to the personal competences, because I think in this area it's very complex care, because there are all kind of issues which relate. So, and that's very much underestimated. And then it relates to what Nele said. It's also very low paid. Because it's seen as, well, just prisoners, and we shouldn't. So there, I think a good curricula of what are all these needed competences, these complex things, is highly needed.
Yeah, definitely.
Can I say one more thing about these personal competences? In Holland, when you make an appointment with the doctor, you fill in a form. This goes to the medical department, and then before you see the doctor, you see the nurse, and the nurse determines if you are sick enough, or if your case is serious enough to go and see the doctor. So, and these people are not qualified, in my opinion, to make that judgment. You know, that's also a danger, because of their lack of education. In some cases, they are not able to judge if you need to go to see the doctor or get sent back to your cell.
Yeah, definitely. Yeah. So I think we also should take that into account. Peter, you want to say something?
Just a comment on what Gerard said. I see that the issues you bring up are kind of extreme situations that also exist outside the prison situation. The issue of illness benefits, that's also outside the prison situation, where some people want to be have a diagnosis or called sick because they don't want to go to work. That's especially in some countries with sick notes. This double role of GPs, that's also the issue when you look at the situation of occupational doctors who have to take into account the position of a patient and of a employer. So and these nurses in their role in triage is also, when you call your GP, you get the assistant who first asks you to find out whether it's really important that you visit the GP or not. So you find the same things also outside the prison situation, but they are much more extreme in this prison situation. So we should take that into account.
Yeah, no, definitely. Sukma, did I see your hand?
No, but actually, I think role of referral system, and what Gerard said that about the nurse, the competency of the nurse to judge which patient is more urgent than the other. It's important. So I think the GP, the role of the GP is to differentiate, yeah, to you know, in as a doctor we learn about triage, how to what to care of which patient first.
Yeah.
Yeah. So I think I agree with Gerard that it should be doctor, not the nurse, who decide. Oh, you can only see me, see the nurse as your therapist, but I think it should be a doctor. A family doctor is very important, and the referral system, I think it's also very important. From if you want to refer to the surgeon or other specialty, I think it's a main issue also. Thank you.
Yeah. Yeah, no, thanks so much, Sukma, for your contribution. Yes, indeed. So I think in many countries already the nurse is doing the triage, and I think nurses are well trained and well qualified to do so. So I think that is a discussion point between you and us. And then secondly, that I think is also, we should definitely include that in the list of Peter. It's not only had the referral from prison to community, but it's also between specialists and so on. I think that, but it has to do with the continuum of care and to make sure that referral is done well. I thank so much for that contribution. I had also one contribution to your last slide, and then we go to this one, that we also should take into account capacity. So I think that is also an issue. So next to competence, also capacity, how many primary healthcare service delivery do we offer in a prison? And I think it should be 24 hours, 7 days. But how do we organize that? Then we move on, Peter.
Yeah,
and I hope you don't mind if we continue a little bit longer than 1:30. Yeah.
That's fine. And here I have put a number of keywords that relate to the policies, both of the people involved in prison health, but also in primary care that is related to prison health. The first thing is that the policy agenda is very one-sided. Sukma already mentioned that in policy making and in how policymakers talk about prisons, they say, well, it's for punishment, and I think it's also very important that other aims should be mentioned. For instance, the prevention of recidivism. And the opportunities to improve care and fight inequalities in health, given the composition of the population of prisons. So the policy agenda should change from a single focus on punishment. The governance has been mentioned already, whether it's Ministry of Health or Ministry of Justice or combinations. Organization of care, well, this is partly the capacity and team skill mix point that has already been made, where I think it's important that there is also a good link with social care. Accessibility outside hours of care, that related to the problem that Gerard has described. Integrated care, which is both integration within the care in the prison, but also the longitudinal integration of care with the community care and with specialist care, as Anke rightly mentioned. And what I got from the examples in the webinar last time in January is the importance of some transfer policies that that not only medical information but also other information is transferred, and that people are helped in the transfer from prison to the community. And I was thinking of hospitals that have developed this situation where they have transfer nurses for the situation to assure the continuity of care between hospital and community care. So you could imagine that you need something like a transfer nurse or a transfer social worker for the continuity between the prison and the community situation. Diederik, you have something else now on the screen. You've put participant list on the screen.
Yeah, okay. Yeah, and Nele had to leave us. She gave a note. She gave a note that she had to leave. She has patience, but she thanks Gerard for his story. So I suggest we take 5 more minutes. Is that okay for everyone? Is there one more slide, Peter, after this one?
Yes, only one. Yeah.
Okay.
And it's shorter.
Okay, because I think what you said, prevention of recurrence for the policy agenda is of course very important, but I think alternative punishments are also very important. That you try to find punishments where you don't have to put people into prison. Is there any contribution? And we have someone from Uganda, very welcome. Any contribution to this list of data? From Veerle, Sukma? No? Shall we then move on, Peter, to your last slide?
Yeah. Well, Diederik, if you would put the last one on. As I said, there are 3 pillars for the European Forum, and the third pillar is the perspective of researchers, and I've added research funders. There are no dedicated research programs that I'm aware of on research on healthcare in prisons. So that's a neglected area, and there is more research on health of prisoners, but few on how to organize care and how to organize primary care in a good way. The focus should be on the organization of care and not only trials to find out the effectiveness of specific interventions. There are a lot of examples of specific mental health programs and drug abuse programs that are evaluated for the prison situation, but of course these are not integrated in the whole of healthcare for a person. And this should also include the quality of care, which was mentioned previously by Nele. Quality, it's not only providing care, but it's also providing good quality care. The third issue for researchers is the importance of the context. It's partly the organization of prison health care that differs, but it's also the link between the prison healthcare system and the wider healthcare system that is an important context. So the prison healthcare and the wider healthcare system, the links between them is an important area that should be studied further. And finally, international comparative research, learning from other prison care systems and healthcare systems to improve the healthcare systems in the country where each of us is working and living. So these are the few bullet points on research. I think they're important because without a good evidence base, we're not able to improve care, and then it would just be experience based, but it should also be based on evidence that we systematically collect.
Yeah, thanks so much for that. Yeah, very good. So focus on the organization of care. I think that with Gerard's story, I think we all can agree on that. Are there any other ideas for the research agenda, Diederik?
Yeah, I'm triggered by this international comparative research, of course, because we are a European Forum for Primary Care. We want to bring this together. And I heard Gerard saying, well, in Holland it's bad, but in other countries it's better. So then I'm curious, what are you referring to? But I'm also curious, for example, what is the experience of Veerle? Is it as bad as Gerard presented it for the Netherlands, or was it is it in Belgium better organized? So both, Gerard, maybe you can say a few words about other countries you've heard about.
For example, in Germany there is a nurse in the prison 24/7. There's always somebody available. That makes a big difference. And yeah, the care there is a lot better, is what I hear from former inmates, and it's just better organized. There's more staff, there's more care, there's 24/7. That is the main issue. If you get a heart attack in a Dutch prison, you have a very good chance of not surviving. And yeah, and in Scandinavia and in Germany, that is better organized. That is what I know about it.
Yeah. Okay. And Veerle, she sent a note. But Veerle, are you still there? Yeah, please. Yeah.
Yes, I am. I was involved in this research that I linked to here, in which we talked with some prisoners on health, but also with some, we looked at the organization of healthcare, and actually we also looked at the Dutch system. I wasn't very actively involved in this research, but for instance, I remember that we were a little jealous even of the situation in the Netherlands in terms of education of staff. In Belgium, prison doctors don't have a specific training to be a prison doctor. So there's no specific training course that you should take, while in the Netherlands, this was more developed. And actually the idea of triage by a nurse, we were also a little bit jealous on, because as far as I know, actually for us, it's the penitentiaire beambte, so the guard, that kind of does a first triage and decides if people need urgent care or not, because we also don't have a 24-hour nurse in the prisons, and our nurses are not active in triage. They assist doctors if needed. So in some aspects, we did look at the Dutch system as something to learn of, but it would be my idea that it would be good to look at the different countries and look at the strong points in the different countries, because I'm sure that Gerard's point is very valid, that there's a lot of points of improvement in the Dutch system as well.
Yeah. Okay.
Another point that links to research, if I may very quickly touch upon it, is the accessibility of data in prisons. I don't know if this is also the case in other countries, but in Belgium, the data in prisons, the health data is quasi non-existent. So there's almost no electronic medical data, which also makes doing research there very, very difficult.
Yeah, and I think we encountered that problem as well here in the Netherlands. Yeah. Okay, thanks so much, Veerle, and thanks so much for sharing the link to that study. And I think we really can use that also for our position paper. What I hear is, is there someone else with an urgent need to say something, or with a good idea for input? If no, then I suggest that I wrap up. Thanks all for joining this webinar, and thanks especially to Gerard. Really very, very helpful that you joined us and told your story and shared your story with us. And Gerard, you also said that you are interested in contributing also in the next steps. So I think that's also good to keep that in mind if we are going to develop the position paper, or if we are doing something with regards to research to involve Gerard and maybe also others as well. I think with this webinar, we really have taken a next good step in our position paper. The whole idea is that we are going to present it during the next conference for the European Forum for Primary Care. And well, you are on the list, so we keep you in the loop with all the information. And I think, Diederik, you will share this webinar also through the usual channels of communication, right?
Yeah, what I want to add to that, we will upload the recordings in our online platform, which is restricted to EFPC members or invited people. And we will do the same with the presentation of Peter, if you agree, and I think you agree.
Sure.
So that presentation will be also distributed through email. But then you have all the information, and if you want to join the working group, if you want to be more active, and in particularly ask for the Belgian participants to become more active. That would contribute very well to the position paper and to our work towards Bergen conference. And Veerle, I think if we will meet each other in Bergen, you will be there, I assume. So that would be great.
Okay, so then once again, thanks all and have a good day. En Gerard, I will call you later. Ja, ik bel je later even vandaag. Ja?
Okay, thank you.
Thanks a lot.
Bye bye.
Bye.
Have a good day. Bye. Thank you.
Nice sharing, Gerard.
Bye bye.
Bye. Bye.
Bye.